Hello everyone. So in this video, uh, I will be talking about the permanent method of contraception, that is about sterilization, and I will be talking about male sterilization and female sterilization, and let's move on. So talking about sterilization, it is a permanent method of contraception that is done either for male or female. The sterilization is highly effective and very safe method, and in contrast to other methods which are reversible or temporary, the sterilization should be considered permanent. And if a woman who have tubal sterilization wish to conceive, in IVF, in vitro fertilization can be used. Otherwise, tubal reconstructive surgery is also an alternative. So for male, anastomosis of vas deferens could be done. The operation done on male is called vasectomy, and that done on the female is called tubal occlusion or tubectomy. So what are the two methods of sterilization? For male, it is called as vasectomy, and for female, it is called as tubal occlusion. And before the performing any permanent procedure, we have to do the couple counseling, also known as pre-sterilization counseling. Sorry for my handwriting. And this includes any discussion on the issues like desire for the individual partner, procedure selection, failure rate, risk and side effect, issue of reversibility, and reversal is more likely to be successful after a laparoscopic clip compared to laparotomy procedures. However, risk of ectopic pregnancy is there, and also option for alternative long-acting reversible methods should be given to the couples. And the pre-sterilization information and counseling includes both verbal and written information, that is consent. It is done with both partners together, and it includes information with other method, including a long-acting reversible contraceptive, and it includes information about failure rate and complications. And we have to also discuss about advantages of vasectomy over tubectomy. The advantages of vasectomy over tubectomy can be done is that vasectomy can be done in clinic under local anesthesia. There is no entry to the peritoneal cavity, less time needed, that is less than 20 minutes, and complications are very less. There is no hospital admission or stay. They are highly effective, there is minimal side effect, and low cost, and vasectomy is very simple to perform. So that's why vasectomy is preferred to the tubectomy. And now we'll move on to the male sterilization, that is about vasectomy. Vasectomy is a permanent sterilization operation done in male where a segment of vas deferens of both sides are resected and the cords end are ligated. The advantages of vasectomy are, as we have already said, it is very simple procedure, and it is performed with minimal training, and the operation can be done as an outdoor procedure or in a mass camp, even in the remote villages. The complication both immediate and late are very few, and the failure rate is very minimal, that is 0.15% only, and there is a full chance of success of reversal anastomosis operation. So, and overall cost is also minimal in terms of uh, equipment uh, hospital stay, and doctor training. The expenditure is very less, and there are some drawbacks of vasectomy. What are the disadvantages is that additional contraceptive protection is needed for about 2 to 3 months following the operation, till the semen becomes free of sperm. The frigidity and impotency can be occurs, and this is mostly due to the psychological frigidity or impotency. And the selection of candidate, with a sexually active and psychologically adjusted husband having the desired number of children is the ideal choice for the candidate of the vasectomy candidate. And about no scalpel vasectomy, NSP, it is commonly done at present in India, and it was popularized by Dr. Li Sung Kwang of China in 1991. Now we will discuss about techniques of no scalpel vasectomy. Firstly, the written consent of patient is taken. Following the counseling, the operation is done as an outdoor procedure or in the camp. The local area is saved and cleaned with povidone iodine solution lotion. The full surgical asepsis has to be maintained during the operation. The procedure is done through the local anesthesia, and firstly the area is palpated. The basa is palpated with 3 fingers of left hand, index and thumb in the front and the middle finger from the behind. This is done at the level midway between the top of testis and the base of penis. And the basa is grasped with ringed clump. Basa is grasped with ringed clump. Ringed clump applied perpendicularly 90 degree on the skin overlying the basa. The skin is punctured with sharp pointed end of the medial blade of the dissecting forceps. This is dissecting forceps. The medial blade of dissecting forceps. The skin is punctured. The puncture point is enlarged by spreading the tissue, the darter's muscle and spermatic fascia, inserting both the tip of the dissecting forceps. The basa is elevated with the dissecting forceps. The basa is elevated with the elbow dissecting forceps, and the basa is it is holded with the ringed clamp. At least 1 centimeter of the length of basa is made free and mobilized. The basa is ligated at two places 1 centimeter apart by number 00 chromic catgut, and the segment of the basa in between ligature is resected out. Division of the basa should be accompanied by fascial interposition or dithermy. This reduces the chance of failure rate. Hemostasis is secured. There no skin puncturing is needed. One dressing is done and the small pressure bandage is applied. The same procedure is repeated on other side. A scrotal suspensory bandage is worn. The patient is allowed to go home after half an hour. The histological examination of excised segment of basa should be done for confirmation if the surgeon is in any doubt. So that was our technique of vasectomy. After that, we give the patient the advices about the antibiotic injection, Penidur, local LAIM is given, is administered as a routine, and analgesic is also prescribed. Heavy work or cycling is restricted for about 2 weeks. We should not allow him to do heavy work for 2 weeks or cycling, and while the usual activities can be resumed forthwith. For checkup, patient should report back after 1 week or earlier, and if complication arises, he should report back after 1 week. And additional contraceptive should be used for around 3 to 4 months. For additional contraceptive for 3 to 4 months, and no scalpel vasectomy takes less time, helps faster recovery due to less tissue injury. The complications are very significantly less. And so now talking about precaution, as we already have said, man does not become sterile as soon as the operation is over. The semen is stored in the distal part of the basa for around for 3 months. So it requires about 20 ejaculation to empty the stored semen. 20 ejaculation. So the semen should be examined either by 1 test after 16 weeks or by 2 tests at 12 and 16 weeks after vasectomy. And if 2 consecutive semen analysis showed absence of spermatozoa, the man is declared sterile. Till then, additional contraceptive like condom or DMPA to the wife should be given. And about the complication of vasectomy, the complication of no scalpel vasectomy is very less. The immediate complication can be the wound sepsis, which may lead to scrotal cellulitis or abscess. There can be scrotal hematoma. The remote complications are frigidity or impotency, mostly due to psychological in origin. There can be sperm granuloma due to the inflammatory reaction to sperm leakage, and this can be prevented by cauterization or fulguration of the cotton. The chronic intrascrotal pain and discomfort, the post-vasectomy syndrome. This may be due to scar tissue formation or tubular distension of the epididymis. chronic intrascrotal pain and discomfort. And there is also there is no increase in testicular cancer or heart disease, but and also but there can be spontaneous recanalization, and that is also very rare. It occurs in 1 in 2000 population, spontaneous recanalization. so so that was about the male sterilization procedure. Now we will talk about female sterilization. So now we will discuss about female sterilization. The occlusion of fallopian tube in some form is the underlying principle to achieve the female sterilization. It is the most popular method of terminal contraception all over the world. The indication for female sterilization are for the one is the obvious family planning purpose. This is principal indication in the most of the developing countries. Second was a socio-economic. An individual is adopted to accept the method after having the desired number of children. Third one is medical surgical indication, that is for therapeutic for female partner. The medical disease such as heart disease, diabetes, chronic heart disease, chronic renal disease, hypertension are likely to worsen if the repeated pregnancies occur. During third time repeat seizure section or following repair of prolapse to avoid the complication. And the risk reducing salpingectomy as a preventive method against serious serous ovarian and peritoneal cancer. This is on. So about time of operation. During the period or period, if the patient is otherwise healthy, the operation can be done 24 to 48 hours following delivery. Its chief advantage is that technical simplicity. Hospital stay and rest at home following delivery are enough to help the patient to recover spontaneously from the two events, that is delivery and operation. Next one is the interval. The operation is beyond 3 months following delivery. If the operation is beyond 3 months, it is called interval. 3 months after delivery or abortion. The ideal time of operation is following the menstrual period in the proliferative phase. And the third time for operation is concurrent with the medical termination of pregnancy (MTP), and at time of CS and at time of cesarean section. The sterilization is performed along with the termination of pregnancy. This is mostly done especially in the urban center. The concurrent with cesarean delivery with prior consent. Now the method of female sterilization. The occlusion by resection of a segment of both fallopian tube, commonly known as tubectomy, is widely accepted procedure. Concurrently, the occlusion of the tube with ring or clip or electrocoagulation using a laparoscopy is gaining popularity. Hysterectomy during the childbearing period has got an incidental sterilization, but it should not be done for sterilization purpose. So talking about tubectomy. Tubectomy is an operation where the resection of a segment of both fallopian tube is done to achieve the permanent sterilization. The approach may be abdominal and vaginal, and in abdominal we have conventional and the mini laparotomy. Talking about the conventional laparotomy procedure, we have 3 steps. First one is anesthesia. The operation can be done under general anesthesia, spinal anesthesia, or local anesthesia. In the mass camp, the local anesthesia is preferable. In case of local anesthesia, the pre-medication with injection of morphine 15 mg or the injection pethidine 100 mg with phenergan 50 mg intramuscular is to be administered at least 30 minutes prior to surgery. The incisional area is infiltrated with 1% lignocaine. And second step is incision. In the puerperal cases where the uterus is filled per abdomen, the incision is made 2 finger breadth below the fundal, and in the interval cases the incision is made 2 finger breadth above the symphysis pubis. The incision may be either midline or paramedian or transverse. The abdomen is opened by the usual procedure. The third step is delivery of tube. The index finger is introduced through the incision. Finger is passed across the posterior surface of the uterus and then to the posterior leaf of the broad ligament, from where the tube is booked out. The tube is identified by the femoral end and the mesosalping containing the utero-ovarian and stomach vessels. There are various techniques of tubectomy. We will see all these 5 techniques in very short. First one is Pomeroy's technique. We will see in the picture. So we'll talk about Pomeroy's technique. This three picture shows the Pomeroy's technique. We firstly a loop is made here. The loop is made by holding the tube by an Ellis forceps. Loop is made by holding the tube by Ellis forceps in such a way that the major part of the loop consists of mainly of isthmus. This is isthmus part, and this is the isthmus part, and it is 1 inch, as we can recall from anatomy. And the major parts of the loop should be isthmus part, and some part of the ampullary part, that is ampullary part, some part of the ampulla. And although and through an avascular area in the mesosalpinx, or needle is avascular part in mesosalpinx, or needle is threaded with a number 0 chromic catgut suture, and is passed, and both the limbs of the loop are firmly tied together. Both the limbs, after making loop, both of the limb of the loop is firmly tied together by number 0 chromic catgut suture. As we can see, this first loop is made, and after loop is made, it is tied off with the suture. And we can see after the tying the suture, the about 1 to 1.5 centimeter of the segment is excised. That is the loop distal to the ligature are excised. So as it is evident, we can see in the picture. And finally, the tube is so excised as to leave behind 1.5 centimeter of intact tube adjacent to uterus. This is 1.5 centimeter of the segment of the intact tube adjacent to uterus. The segment of the loop removed should be this removed segment should be inspected to be sure that the wall has not been partially resected, and it has to be sent for histology. The same procedure is repeated on the other side. Because of the absorption of the absorbable ligament ligature, the cotton become independently sealed off and are separated after a few weeks. So the advantages of this Pomeroy technique of tubectomy is that it is very easy, safe, and very effective in spite of simplicity of the technique. And the failure rate is 0.1 to 0.5%, and the cotton become independently sealed off, and they retract very widely from each other. So that was about Pomeroy technique. Nextly, we will see about the Uchida technique. A saline solution is injected subserosally in the mid portion of the tube to create a bleb. The serous coat is incised along the antimesenteric border to expose the coat. To expose the muscular tube. The serous coat is incised along the antimesenteric border to expose the muscular tube. The tube is ligated with the number 0 chromic catgut on either side, and around 3 to 5 centimeter of the tube is resected out. In both sides the chromic catgut is placed, and the ligated proximal stump is allowed to retract beneath the serous coat. The serous coat is closed with fine suture in such a way that the proximal stump is buried, but the distal end distal stump is open into the peritoneal cavity. You can see here, it is open into the peritoneal cavity. So there is no failure in this method as it observed so far. This was about Uchida technique. And thirdly, we have the Irving technique, EIR, BING, Irving method. The tube is ligated on either side, and the mid portion of the tube between the ties is excised The free medial end of the tube is then turned back and buried into the posterior uterine wall, creating a myometrial tunnel. And another technique we have is the mad linear method. It is easiest method, and the loop of the tube is crossed with an artery forceps. The crossed area is tied with black silk. The loop is not excised. The failure rate is very high in this, and up to 7%, and it is abandoned in preference to the Pomeroy technique. So this is mad linear method. You can see it's the cross segment, loop of amputative is elevated, the tubal segment is not removed, tubal ligate over the crust area. So these were the some major technique. Pomeroy, which is Irving, mad linear, and Kroner. Kroner means it is a cloner method of hemirectomy, and it is not a common procedure. Finally, after the operation is over, the abdomen is closed in layers. Antibiotics are given routinely in the post-operative period. The abdominal stitches are removed on the 5th day and the patient is discharged. However, if the patient has satisfactory post-operative progress, she may be discharged after 48 hours. The stitches may be removed in the outpatient department. Now we will shortly talk about mini laparotomy, the mini lap procedure. When the tubectomy is done through a small abdominal incision along with some device, the procedure is called as mini lap, and it has been popularized by Uchida of Japan since 1961. The steps of mini lap include firstly the anesthesia. It should be under local anesthesia. The plan of incision should be done as described in conventional method, but the incision should be 1/2 to around 3/4 of the inch. Specially designed irritator may be introduced after the abdomen is opened. The uterus is elevated or pushed to one side or the other by elevator that has already been introduced transvaginally into uterine cavity. This helps the manipulation of tube in bringing close to the incisional area. The appropriate technique of tubectomy is performed on one side and then repeated on other side. The peritoneum is closed by purse string suture. One advantage is that it can be performed with satisfaction of patient. It also benefits the organization. That's turnover of the patient per bed is more than that in conventional method. The patient is usually discharged after 1 to 2 days. And the next technique is we have vaginal ligation. The tubectomy is done through vaginal route is called vaginal ligation. It can be done along the vaginal plastic operation or in isolation. When done in isolation, the approach to the tube is through the posterior colpotomy. Surgeon need additional skill of vaginal surgery, and it can be done under spinal or general anesthesia. It takes longer time, and laparoscopy may be needed sometime. Its complications are like hemorrhage or broad ligament hematuria and really rectal surgery. And that was all. And we have another thing known as laparoscopic sterilization. The laparoscopy is the commonly employed method of endoscopic sterilization. It has gradually become more popular, especially in the camps. The procedure is mostly done under local anesthesia. The operation is done in interval period concurrent with vaginal termination of pregnancy or 6 weeks following delivery. It should not be done within 6 weeks of delivery. The procedure can be done either with single or double puncture technique. The tubes are occluded either by Sialistic ring silicone rubber with 5% barium sulfate, devised by Fallop or Filsey clip. This is Filsey clip is made of titanium lined with silicone rubber. Only 4 mm of tube is destroyed. The failure rate is 0.1%. The Halka Clemens spring clip is also used. The electrosurgical method can desiccate the tissue by healing. Unipolar or bipolar method of tubal coagulation is used. Bipolar cautery is safer than unipolar one, but it has higher failure rate. Laser photocoagulation is not popular because of high recanalization rate. This is called laparoscopic tubal sterilization by Filsey clip. The Filsey clip is made of titanium and inner surface allied with silicone. So these are the instruments for tubal sterilization. So what are the hazards of tubal sterilization? The immediate complications are like these related to general anesthesia and particular method used in sterilization, complication and the remote complication include they are very specific for the approach and they are related to sterilization. There are general complication like occasional obesity, psychological ups, and the gynecological complication like chronic pelvic pain, congestive dysmenorrhea, and menstrual abnormality in the form of menorrhagia, hypomenorrhea, and irregular period. So the pelvic pain, menorrhagia along with cystic ovary constitute a post-ligation syndrome. It may be vascular in origin. However, the incidence can be minimized if the blood vessel adjacent to major sulfins are not unduly disturbed. So that was all. And talking about failure rate of this tubectomy, the overall failure rate in tuber sterilization is about 0.7%. The Pomeroy's technique has the lowest failure rate, that is 0.1 to 0.5%. In contrast, the Mad Leaners has the highest, up to 7%. The failure rate is increased when it is done during hysterectomy or during cesarean section. The failure rate of laparoscopic sterilization depends upon the individual method, and the failure may be due to fistula formation or spontaneous reanastomosis. The mortality following tubal sterilization is very less, around 72 per 1 lakh. And for the reversibility, the informed consent must be obtained after adequate counseling. The couple must understand the permanency of the procedure, its occasional failure rate, the risk and side effect, and its alternatives. Also, unfortunately, regret is also not uncommon. The microsurgical technique give excellent result for tubal reanastomosis. The pregnancy rate after reversal are high following use of clip and rings.